Well, everyone, I think it's 7 o'clock, and so I think we should get started with the webinar. Welcome everyone to our webinar today looking at multidisciplinary best practices for same-day surgery in total hip and total knee replacement. My name is Jamie Howard, and I will be serving as one of your moderators this evening. I'm an orthopedic surgeon who works in London, Ontario, and I'm the current chair of the Education Committee of the Canadian Arthroplasty Society. My co-moderator is Dr. Claude Laflamme, who's an anesthesiologist in Toronto, and he's chair of Enhanced Recovery Canada. So we're going to try to get into the meat of the webinar here quickly, but I'm just going to lay the groundwork with some housekeeping details here at the start. So I'd like to start with a land acknowledgement, and I would like to begin by acknowledging that the land that I am currently broadcasting from is the traditional unceded territory of the Anishinaabe and the Attawandaronk. And I would like to recognize that my fellow moderator and panelists are all in different territories. And we as a group this evening value the significant historical and contemporary contributions of both local and regional First Nations of Turtle Island. So this evening, we're going to break the event up into a series of segments. We're going to start off with some presentations, first with a patient experience presentation, and then Pascal-André Vendittoli will give us some details on enhanced recovery in orthopedic surgery. We then have 3 panelists, which I will introduce later, all from different areas that are key to successfully achieving outpatient surgery. And we'll have some roundtable questions completed. And then at the end, we've got time for questions where all of you, the participants, will be able to ask questions of the moderators and panelists and try to generate a discussion around this very important topic. I think at this point of the pandemic, we're all painfully aware of how Zoom works, but I would encourage all of the participants to use the Q&A function for any questions they wish to direct, and Claude and I will try to look through those questions and direct them to the most appropriate person during the session. And finally, I'd just like to remind everyone that this session will be recorded and should be available in about a week on the COA YouTube page for you to review at a later time. So with that, I'm going to turn the reins over to Claude to give us a bit of an introduction to why enhanced recovery after surgery is important and introduce our first 2 speakers. Claude? Thank you very much, Jimmy. Yes, as mentioned, I'm Claude Laflamme. I chaired Enhanced Recovery Canada for the past few years. We started with colorectal, gynae, hip and knee replacement, and this is what we will talk about tonight. So this webinar is really to raise awareness and learn about a Canadian multidisciplinary pathway for successful same-day hip and knee replacement. This pathway, which is evidence-based, was created under the governance of Healthcare Excellence Canada, and which guided a team of key opinion leaders, multidisciplinary key opinion leaders, to create the pathway under the direction of Dr. Pascal-André Vendittoli. Dr. Vendittoli has already published literature on the topic, as he has been applying this pathway for the past few years. And you will realize that by optimizing our practice in regards to something as simple as narcotic-sparing analgesia, preventing nausea, vomiting, anemia, urinary retention, and so on, we can definitely, it can definitely lead to a successful and safe same-day arthroplasty for many patients across the country. In addition, the pandemic has hit us, all of us, very hard, and it has imposed a shift in the hospital focus, redirecting resources to the area most in need. And for that, elective arthroplasty in Canada has suffered tremendously. In the report from the Arthritis Society, their report published in June 2021, it's called the Weight Report. It highlights that during the month of April and May 2020, there was 67% less arthroplasty done in Canada. That was at the beginning of the pandemic, and we all know that we're still in the midst of it. So there's a backlog there that cannot be addressed if we don't change, if we don't optimize our practices. So that's what we would like to address with you tonight and give you the tools that are prepared and ready to be used. So before we hear from the tools, let's hear a testimony from a patient
Monsieur Francis Larin, who is an attorney in Montreal, and he will share his experience about having a hip replacement done at Maisonneuve-Rosemont following the guidance of this pathway. Francis, à vous la parole.
Thank you, Claude. And so as Claude mentioned, I'm just a lawyer. So in advance, I want to apologize if I'm using some terms which are not appropriate or not really medical sounding. So, but I thought it was interesting to share with you the experience. So everybody can hear me well? Okay, so just to give you a very quick introduction. So in 2015, after experiencing the usual symptoms, I get right before Christmas, the dreaded diagnosis, so severe osteoarthritis in the right hip. And at that time, as most patients of my age, we don't know what that is. So I was very discouraged. I had images of elderly folks not being able to cross their legs because, you know, the artificial hip would pop out. So clearly, I was not looking forward to get such a surgery. And I guess my family doctor then was of the same opinion, because eventually, you know, the initial plan was just to get some visco injections like Synvisc and Monovisc. And I was told that with that on a regular basis, I would probably avoid any surgery in my lifetime. So needless to say, that didn't happen. So over the course of the next 2 years, I did go through that planned treatment, but the more and more it progressed, the more and more I realized that it wouldn't cut it. I mean, the interval between injections grew shorter. The pain was there to a point where at the end, the effects barely lasted a few days or a couple of weeks. So because of my professional background, I went into a lot of research. So I wanted to find out, so what is out there, like in 2015, in 2016, 2017. And the game changer for me was stumbling across an article in the Montreal newspaper back in August of 2016, where there was a picture of Pascal and his team members, and which basically the title mentioned, "Get a new hip and get back home the same day." And so that intrigued me a lot. I had a friend who went through a much more traditional approach back in 2010, and his experience was awful. What he had shared with me, he was then the same age I was. He was in the hospital for 5 days. It was really painful. He went back to work as a factory manager 3 months later, and he was told he was ahead of the planned recovery timeline. So needless to say, with that as a comparable, I was not too enticed, you know, with going forward. But having read that article, I was intrigued. And so I decided to go forward, get in touch with Pascal's team, and I got my surgery in late November of 2018. And so it's obviously it's a game changer on every level. But just to go walk you through quickly, so on surgery day, we get to the hospital in the morning. I was in the surgery room. Surgery began around 9 with an epidural. I brought my headsets, music, and then I didn't even go through the first song. And with the mild, I guess, sedative that was given to me, went to sleep and woke up at 10 with the surgery done in the next room. On that day, I recall specifically, I had 3 tasks over which I had control. First, to eat. That wasn't a problem. It was probably the best hospital sandwich I've ever had in my life. Second was to go to the bathroom, make sure you didn't have any urinary blockages. That wasn't a problem either. And third and not least was to go with Karina and go up and down a flight of stairs at the Hôpital Maisonneuve-Rosemont. And anybody who's been to that hospital know that it's not your typical down to the basement flight of stairs. It's quite lengthy. And I even added, for good measure, to walk there by myself, you know, with a walker and with the aid of Karina, to the staircase. So all in all, you know, I had to walk about 100 feet, go up and down a flight of stairs, about, you know, 5 hours post-op. And I was simply amazed. And so I was discharged from the hospital at 3:30 p.m. that day. So surgery ends at 10 a.m., 3:30 p.m. I'm out of the hospital. Going back home, you have to drop by the drugstore, pick up the medication for the duration of the recovery, which basically consisted, in my case, I recall, Cerebrex, the equivalent of baby aspirin, and some Tylenol. and then narcotics just in case. And I'm happy to report that I never needed, I've never had the need to go to use even one of those. And so afterwards, the rest was pretty much done at my place. And to this day, I recall the face of the physiotherapist who knocked on my door on day 3, the first visit. And I was opening the door, put the crutches, so I was standing on my 2 legs. And she asked me, "Where's the patient with the hip surgery?" I said, "That's me." And she didn't believe me. And that went very well. So just to give you a timeline, about 10 days post-op, I was back to driving my car. 3 weeks later, I went to a Christmas party at my employer's in downtown Montreal with a cane. And a week later, after that, I started cross-country skiing again. And you know, that friend of mine, that factory manager, he had to have his other hip done in 2020. I referred him to Pascal's team, and the comparison for him was even more incredible, because remember when I told you it took like more than 3 months to go back to work? Now we went back to work at 58 instead of 48, but at 58 after 12 days with the same protocol. So needless to say that it was a game changer. It was a life-changing event. I still am amazed to this day. You know, you are as a patient very scared to some extent. You say, "Oh, am I going to?" You're hesitating. Am I going through with that procedure? And I would say to anyone who's hesitating, please don't, because it's literally a life-changing event. So in closing, and hopefully on a humorous but also very true note, I thought that it was life-changing to such a degree that I've decided to name the artificial hip, and I thought it deserved a proper name. And given one of its key components, I thought that the intended pun was better understood by reading the name than speaking it out loud. So Dana, if you don't mind. So Pascal and Sir Ramic, thank you for that new take on life. So on that, back to you, Claude.
Merci beaucoup, Monsieur Larin. And without further ado, I think it's now time to hear about Dr. Vendittoli, about his experience. And Dr. Vendittoli is an orthopedic surgeon at Hôpital Maisonneuve-Rosemont and La Clinique Duval. And he is also a professor of surgery at the University of Montreal, senior clinical researcher at Hôpital Maisonneuve-Rosemont. And he did chair this ERAS for same-day hip and knee replacement. Pascal?
Thank you very much, Claude. Thank you, Francis. It was very nice to hear your testimony. Thank you to the COA and Healthcare Excellence Canada and Enhanced Recovery Canada organizing this webinar. So as Claude said earlier, in the current pandemic period, we're facing real challenges. We are asked to reduce hospital length of stay, reduce caregiver workload, minimize patient complications, and nosocomial infection. An ideal solution to continue elective surgery is to implement outpatient hip and knee program. But however, in 2020, as you can see here, less than 10% of THA and TKA cases performed across Canada were identified as day surgery. Such small percentage is not enough. Why its adoption is so slow? Changing tradition for success, we have to identify the potential problems. Here are the different adverse events after a standard inpatient TK or THA. Pain, nausea, orthostatic hypotension, bladder retention, wound problem are very frequent, as you can see here. And these problems need to be prevented to achieve success. Each problem may not occur in all patients, but we need to change our practice trying to avoid them all. For example, let's see one very important factor of day surgery failure. Wound discharge is a major factor of anxiety for the patients. It is one of the main reasons for emergency visit after day surgery procedure. There are multiple ways to prevent it. One may decide to put very tight staples, use a suction drain, and apply a large Jones dressing. Is it the best option for the patient? Probably not. Ideally, the select method should be simple, minimize post-op care, allow patient to return to normal activity of daily living as soon as possible. We'll try to see in this webinar how we can do better than this. The ideal way of achieving outpatient surgery success for us and for the patient is to follow the ERAS principles to improve the patient outcome to a level where he's ready to go home sooner and safely. We want to minimize the impact of surgery so the patient can resume their normal life faster, as it was spoke by Francis. But let's make it clear, all patients should benefit from ERAS interventions. Although today's webinar will focus on how ERAS can help us achieving ambulatory surgery success, you should also implement these changes for your inpatient cases. To support the transition of broader adoption of same-day surgery across Canada, Healthcare Excellence Canada and Enhanced Recovery Canada formed a group of 20 experts, including anesthetists, nurses, pharmacists, internists, nutritionists, physiotherapists, surgeons, and patients to create the first consensus clinical pathway for inpatient and outpatient hip and knee arthroplasty following the ERAS principles. I invite you to visit the Healthcare Excellence Canada website, where you can find all the documentation in French and English. The pathway has been endorsed. The pathway has been endorsed by the Canadian Orthopaedic Association and the Canadian Arthroplasty Society. To facilitate implementation, the pathway includes order templates and data collection measurement guidelines to assess your progress. First principle of an optimized recovery program is to follow a multimodal approach. Each of the potential problems, as mentioned before, will be prevented by multiple interventions. This combination of intervention allows reducing the dose, intensity of each specific action, and by the same way, minimizing its side effect. Multimodal approach requires the collaboration of all team members. Success of the program depends on the actions of each collaborators. Everybody needs to keep the patient's outcome as their own priority. Sorry, again. ERAS outpatient program starts in the office. Following these inclusion-exclusion criteria, approximately 60 to 70% of our patients are eligible. It is easy to perform outpatient surgery by selecting only the champions, but it will limit its application to your whole clientele. Your ERAS program should be good enough to include the majority of your patients. Outpatient surgery implies a very limited time with the patient on the surgery day. Patient education and engagement a few weeks ahead of surgery is then very important. Patient booklets have been prepared by our team, Enhanced Recovery Canada, and they are available in both French and English on the website if you want to download them. These booklets will become patient's source of information for the whole perioperative process, and they must keep them at all time during the whole perioperative care. Another great option for patient engagement and education is the internet site precare.ca. The patients can find 8 videos of 2 to 4 minutes to help them prepare themselves for their surgery or follow the recovery program.
Chapter 4. the day before and the day of surgery. The day before you come to the hospital, you can eat normally up until 6 hours prior to surgery.
So these videos are offered in multiple languages and comprehensive for most patients. Preoperative patient optimization is also a very important piece of the puzzle. Ahead of surgery, all patients' modifiable risk factors need to be assessed and taken care of. Examples are anemia, diabetes, hypertension, risk of urinary retention, malnourishment, etc. Patients should also be advised to stop smoking or reduce excessive alcohol consumption. Timing of this evaluation before surgery should allow enough time to correct the identified problems. Usually 6 weeks is ideal. On the surgery day, we recommend a limited fasting protocol, allowing patients to eat solid food up to 6 hours before surgery and clear liquids up to 2 hours. Patients should take a chlorhexidine shower to reduce the infection risk. As a multimodal preemptive medication, including 8 drugs, will be given in our protocol to the patient 1 to 2 hours before surgery time. The ideal anesthesia for the orthopedic patient may be different than for other surgical procedures. It should minimize or avoid loss of motor function, avoid opioids and benzodiazepines, reduce postoperative orthostatic hypotension, and the risk of bladder retention. The anesthetist plays a major role in the team and for the success of the outpatient procedure. In the consensus pathway, we propose 2 different options. Both are opioid and benzodiazepine free. If surgeon's surgical time is short and predictive, you can use a short-acting spinal with chloroprocaine or mepivacaine. And another option, breaking traditions, is a multimodal technique combining a light epidural with propofol deep sedation, as you can see on the right. The patient with this technique keep full motor function during the whole surgical procedure. Regarding the surgical technique, we recommend a technique and implants allowing full weight bearing and unrestricted range of motion after surgery. You should minimize soft tissue dissection and perform a careful hemostasis. We avoid tourniquet for TKA because many patients complain of thigh pain when it is used and no drain is left in the joint. Another key part of the protocol is the local anesthetic infiltration cocktail, including ropivacaine, adrenaline, and toradol. As you can see here, the recommended dose is very high, 400 milligrams of ropivacaine in 200 cc of saline. Such large dose is very important to achieve the full benefit of the technique. As discussed earlier, wound management is very important. So we need an optimized wound closure that is simple, minimize post-op care, and allows patient to return to normal activity of daily living. We suggest a subcuticular skin closure and skin glue to seal the wound. It will be a barrier for contamination. Patient will be allowed to shower. There will be no staple removal. It reduces wound discharge and dressing change. Overall, it improves patient satisfaction and simplifies post-op care. After leaving the operating room, we want to use oral analgesics alone, remove all catheter, and resume normal diet as soon as possible. Patient will be mobilized 2 to 4 hours after surgery and leave home after physiotherapist evaluation. Preparing a safe return home is very important. We provide an emergency contact number and make sure they have their information booklet with them. I would suggest you reading the great paper just published by Ortho Evidence, on the rise in return to the emergency department after outpatient surgery. This is certainly not something we want to aim for. What are the results of an ERAS outpatient program? In these two studies that have been published by our group, you can find the objective and the subjective result of the presented pathway. Our protocol is very successful. In addition to achieve early patient discharge, we obtain a 50% reduction of the adverse event rate in the ERAS group compared to the standard inpatient protocol. As expected, ERAS was very effective, reducing the most frequent adverse event like pain, nausea, headache, anemia, hypotension as example. Functional recovery, as it was presented by Francis, was much faster, 2 to 7 weeks sooner in the ERAS arthroplasty patient in comparison to the standard procedure. And these results are the result of patients who experience both procedures. Such faster recovery may have a significant societal economical impact. Estimating only the direct cost, we saved $4,000 per TKA and $1,500 per THA. The economical benefit of ERAS outpatient program are major. Regarding patient satisfaction, patients were significantly more satisfied by the ERAS procedure regarding 5 main aspects: time at the hospital, pain management, speed of recovery, wound closing. In a Canadian public system where the patient have limited financial benefit to leave the hospital sooner, such results favor important patient engagement. As you can see here, patients who experience both protocol, they report a clear preference for the ERAS procedure, with 85% favoring this protocol.
The charts in advance, I don't need to see them.
In this excellent meta-analysis by Author Evidence again, they concluded that outpatient THA and TKA is a non-inferior procedure in comparison to inpatient. With the result I just presented and shared with you, when including ERAS principle, we showed that we can do much better than achieving a non-inferior result. The benefits of an ERAS outpatient protocol are very important for the patient. We reduce their complication rate, improve the speed of their recovery, and provide a surgery with less pain. For the administrators, we reduce cost, improve beds availability, and improve the organization efficiency. For us as professionals, we have the satisfaction to do our best for the patient. Implementing an ERAS outpatient protocol in your institution is a continuous process. I would suggest starting by incorporating ERAS interventions for your inpatient cases until you feel confident to leave the patient go home the same day. Please visit Healthcare Excellence Canada website to find all the resources to help you implementing all these changes. Thank you very much for attending this webinar, and I'll be very happy to answer further questions later on. Claude,
thank you
yours.
very much, Dr. Vendittoli. And we already have questions coming in the Q&A box. So I would encourage you to continue to send your questions, and some of the speakers will answer by text. Some other questions will be answered during the question period. So now I think it's time to hear from the other members of this multidisciplinary team. And I would like to invite Jamie to lead the group.
Thanks, Claude. So we're going to go into a bit of a roundtable session here, and we've got 3 experts in different areas of the the pathway that a patient would engage in either an ARS enhanced inpatient stay or an outpatient surgery. So just to start off, I'll introduce our panel. So first we've got Dr. Jacques Smith. He's an anesthesiologist in Victoria. He originally completed his training in South Africa, came to Canada in 2001. And he's been part of the local team in Victoria that's been instrumental in creating a change towards same-day arthroplasty and revamping their arthroplasty care pathway to reflect the principles that Pascal just talked about. We also have Karina Pellei, who's a physiotherapist with a master's degree in biomedical sciences, who works at the Hôpital Maisonneuve-Rosemont in Montreal. She's been involved in implementing the same-day surgery with Pascal and worked closely with current surgical patients day to day. And finally, Mélanie Boutin is a nurse clinician with decades of experience in various nursing roles. The last year, she's been at Duval Orthopaedic Clinic in Laval, Quebec, working closely with patients to optimize their preoperative factors. So thank you, all three of you, for participating in the panel today. So if I was to, I'm going to ask some questions, and let's imagine a patient. I'm going to kind of walk the patient through all of your areas. So Mélanie, if we started with you, and if we had a patient at the preoperative area, what is your role? And can you tell us what actions you would take to kind of make sure that the patient's going to succeed and contribute well to this protocol that we've heard about?
There is a real opportunity for us to optimize the patient in the pre-op period. Working in a collaboration with the GP, general practitioner, I work on all modifiable risk factor within 6 to 8 weeks before the surgery. As early as the first meeting with the patient, my role as a nurse, it's a target health problem that could be obstacle to implantation. I go through all the exclusion criteria. I evaluate with them problematic drug allergy and tolerance to certain drugs. I suggest quitting smoking. I help them in reducing excessive alcohol consumption. We study and treat the patient with anemia and target a hemoglobin level higher than 130. Diabetic patients are optimized to obtain glycosylate hemoglobin lower than 7. We also optimize high blood pressure, the risk of urinary retention, malnutrition, and many more. We also focus on past cardiac and pulmonary problems. To coordinate with a specialist, it is necessary to be optimal for the surgery. All of this intervention can prevent early postoperative problem affecting the success of the outpatient program. Okay.
Great. Okay, so we'll assume the patient's been optimized appropriately. Jacques, I'll go to you. So can you tell me if you're planning an anesthetic for somebody who's going to go to a same-day arthroplasty, what do you do differently to achieve mobilization and do an anesthetic that lets us get the patient out of the hospital? Because one of the things I think the surgeons on the call are going to be challenged with is it's the other side of the drapes, right? So if we start making suggestions, people get mad at us if we start saying what we think should happen. So what do you do and what should we see?
Yeah, that's such a good point. It's funny how territorial we can become. That's true. I mean, I think that what Dr. Vendittoli described in this protocol is really fundamental. And I do want to encourage everybody on this webinar to have a look at that. And I can vouch from our experience that we built a protocol very almost similar to those principles. And number one, that it does work. I think that that's the first point is myself, I was very skeptical of the protocol when I saw it on paper the first time and when it was presented to me as an anesthesiologist. And only when I saw it firsthand, when we went to visit Montreal and also when we started implementing it in our own system, did I truly believe that that this was possible. It's quite impressive when you become part of this team and you actually see someone walking literally 6 hours after their knee replacement. So to answer your question more directly, I think the concepts of ERAS and surgical daycare and early mobilization really do come down to avoiding those 4 pitfalls, which is pain, urine retention, orthostatic symptoms, and nausea. And the way we avoid them from an anesthetic perspective really is aggressive multimodal oral loading dosing, and getting those timely doses post-operatively. And then number 2 is avoiding neuraxial opioids to all extent. And in our institution, we've also adopted the epidural technique that Dr. Vendittoli spoke about, which results in motor sparing and very, very early resolution of the motor block. You still get a sensory block that's adequate for surgery, but the patients do need a deeper sedation, which we provide with propofol and some adjuvants if they need it. We also avoid, as mentioned, anything that can delay discharge and delay mobilization, such as long-acting narcotics, IV, or benzodiazepines, etc. Anticholinergic agents are dissuaded, so we try not to use those for the reasons stated above. And I think early ambulation is a systems approach. So as much as getting an optimal anesthetic technique involved, it's really important to get the surgical daycare, the PACU nurses, or everybody involved in moving the patient through the system effectively and having physiotherapy around early on.
Okay, great. Okay, so we'll move them, Karina, down the hall. They've had surgery and they're now coming to you. So what do you consider a patient has to do to be ready for discharge for home, like on the day of surgery? If you're trying to have an outpatient pathway, what has to be completed in your mind to be safe to go home?
Well, essentially, the patient has to be able to move. So because you did a great job during surgery, the patient is able to do the exercise, so strengthening exercise for the hip and flexion and abduction. So hip movement, being able to walk, being able to go up and down the stairs. I would say at least 40 meters is the set that you have to have for the patient to be able to walk after the surgery with a walker or crutches or cane, as long as he's stable. And I would say that's what the patient needs to be able to go home.
Okay, I'm just looking in the question and answer. It looks like someone did specifically ask what level of motor sensory function is necessary prior to mobilizing. So prior to starting that, stairs or walk down the hall, do you have a level of return of function? I guess that would depend a bit on the anesthetic technique that you're experienced with.
Yes, of course. And we have a range of strength that the patient needs to have on 5. So I would say a 4, a 3+, the patient has to have that on 5 to be able to move. And as long as he's stable walking, then I can go up the stairs.
Okay, all right, great. Okay, so Mélanie, if I come back to you and you looked at the overall, pathway, because a lot of people on the call are wanting to succeed and avoid the pitfalls. If you were to try to boil it down to what's essential to succeed with an ERAS ambulatory pathway, what do you think would be the key thing your message would be to the attendees?
I believe that getting patient engagement is the most important thing. Indeed, time is very limited of the day of surgery. I need to meet them in the pre-op period and create a bounds of trust quickly. Their collaboration is essential. The best way to get it is the supervision we offer them. From the beginning of the meet, it's necessary to talk so that the team give the same information and the same speech. So patients feel confident. This procedure helps patients reduce their stress. There is also educating a patient in all the detail of intraoperative care in order to comfort them and make them feel aware. They are provided with as much information as possible, but in a simple way. They are given the info. They need to participate in their care. For example, they are taught how to use the pre-op chloroxidine shower. Patients are given a document similar to the one produced by Assistant Recovery Canada. I will suggest the visit the pre-care site website to listen in the educational videos. If the patient is well prepared before surgery, the patient is less anxious, and the chances of success are much higher. I think that success is not only depend on the pre-op period, but also important to offer an effective and simple post-op. For example, at the Duval clinic, I don't use staples, only glue, so no young care to do for the patient. The patient has access to an emergency number for them to contact us in case and concern or complication. It's avoid unnecessary consultation in the emergency room. It is very important to provide a continuum of care. Patient appreciate such a sense of security.
Okay, thank you. All right, Jacques, I'll come back to you. Now, this is kind of touching in your experience of trying to launch something in your own institution. And I know from our institution, we had to get it off the ground. What was the biggest barrier that you faced in trying to change, the pathway that was being used at your institution? Because I think a lot of people on the webinar want to know how to do that. People are quicker to tell you why you can't do something than do something sometimes. So what did you find the biggest barrier was?
Oh, thanks. There are obviously institutional barriers that it may seem insurmountable. And then there are, in my field, obviously anesthesia-specific barriers that need to be overcome. But when it comes to institutional barriers, I think it really just starts with creating the common goal. And as all the presenters have brought to this table already is, we have a healthcare crisis and we have limited resources and we want to get these cases done. So it is a real good starting point to sit around the table and to start looking at enhanced recovery, arthroplasty, and specifically daycare from a huge collaborative approach, which involves administrators and orthopedic surgeons, anesthesia, and physio, etc. So that's the bigger part, the bigger picture. But when it comes down to local barriers and overcoming those barriers, I would say the thing that's probably 2-3 things that it comes down to is convincing people to completely avoid neuraxial opioids. There is lots of dogma involved with that, and people feel like a little touch of fentanyl improves the spinal dense block or whatever. I need to give some hydromorph or epimorph to improve the pain experience. But what we've learned through our experience now of over 2 years in sending patients home, but also implementing these protocols for inpatients and seeing how 3-day stay becomes a 1-day stay. And those are huge for cost savings, also patient care days. I think having seen the success of avoiding something really so simple from an anesthesia perspective has actually led by example and to a point where we completely avoid neuraxial opioids for these patients. The second barrier I would say is avoiding things like, and that comes with education, benzodiazepines, etc. And then finally, I don't want to say finally, but thirdly, what we instituted was through this collaborative process, work with orthopedics to create a clinical audit set that really narrows down and reflects enhanced recovery and so that it is applicable to all patients. And then in our institution, how we overcame most of these barriers and created standardization was that we got sympathy and funding and support from all avenues to create a block room that is staffed by regional anesthesiologists. And as a result, it allows us to massively increase the efficiency of our system, but it also controls for the type of anesthetic that we deliver. So as a result, we control the loading dosing, what the patient gets at what time they get it. We control what goes into the neuraxial because we can control that outside of the operating room. And so in those circumstances, we control the timing of the neuraxial and control what goes into the neuraxial. And subsequently, we follow up with the patients post-operatively to control for some of the side effects that may have occurred. So in our institution, we solve with one way, but I think the biggest barriers really are sometimes dogmatic. And I think it really takes a little bit of a larger step back picture and get everybody around the table to try to achieve common goals.
Okay, that's great. So Karina, I'll do the last question for you here and try to incorporate some questions in the Q&A as well. What are the key elements of doing the exercise program at home? And how do you support those patients at home? Because obviously, as we shrink the amount of time they're in hospital, they're doing more of this at home. So what do you do differently, or how do you support that patient at home, regardless if it was a short stay or an outpatient arthroplasty?
As we saw in Dr. Vendittoli's presentation, he was showing the booklets that we give the patient that they receive before surgery. He also showed the videos that we also teach the patient. They can go and get it. And depending on where you are in Canada, well, in Quebec, we have a CLSC who takes care of them like around 48 hours after their surgery. Some of them go home, some of them go as outside patient in a clinic, and they receive treatment for physical therapy. And they follow the booklet with the progression. They have 6 weeks to 2 months progression in that booklet. They also have our numbers, so they can leave us messages. They can reach it if they have questions, and they do the exercise like that. And if they have any questions, there is always the physical therapist following them at home, as long as they need us for an amount of around 2 months.
Okay, great, thank you. So I think with that, we're going to try to incorporate some questions, because there's a fair amount of questions, Claude, it looks like in the stream. So we're going to start, I'm going to grab some, and Claude, feel free to grab some that you see as well.
Yeah, I can start. I noticed that there was a couple of questions on the surgical approach. So Pascal, are all of your hip done with an anterior approach? And does the approach, a surgical technique, matter?
No, Claude, it's a great question, because there was so much publicity on the internet and lack of science regarding that topic. I believe that the approach doesn't matter to perform an outpatient surgery. At Maisonneuve-Rosemont, we do all our hips through a posterior approach, and they are very successful with an outpatient program. It's really what you do around your surgical technique that makes a difference. The local infiltration, the anesthesia technique, the preemptive drugs, this is much more important than the surgical technique.
Thank you. And talking about the blocks, the spinal, the local anesthetic infiltration. So maybe this question is for Dr. Smit. The question is, how do you get anesthesiologists on board to modify their technique when we have all of these options for to inject local anesthetics somewhere to help for post-op pain control?
So from our experience, I would say the pain experience obviously is very unique, but I think we need to acknowledge that the high volume local infiltration is very effective. And I think that with the preoperative loading dosing is very effective. So, and the question is, when do you employ other forms of regional anesthesia, such as adductor canal blocks, IPACs, or pain blocks that are coming in vogue? And the answer to that is it really actually depends on the patient. So we do all of those and none of those, depends on the patient. So for surgical daycare patients, these are often motivated patients that are well screened ahead of time. They have done well without any blocks, but we do employ a regional anesthesia if the patient is experiencing pain despite the loading doses, which include adductor canal blocks and also pain blocks if they are struggling with pain afterwards. I would say the most patients do really well who are screened for surgical daycare, but there are some of the patients coming through the system that are maybe a one-day stay that are struggling with pain after these kind of procedures, and they do well with regional anesthesia as an adjunct to that. Your question is, how do you convince people? I think that, once again, I think the time of working in isolation is the problem, and I think it really starts with creating small teams of collaboration, of having an anesthesia and an orthopedic champion to work together to sort of lead by example and then show success that way. And we certainly showed that, and it convinced the whole department to change.
Very good. Thank you very much. And I hope that answers a couple of questions regarding blocks and local anesthetic infiltration. And another topic that seems to be quite important here, and that might be for Karina or Dr. Vendittoli to answer, is what are the post-op resources needed for post-op care at home recovery for hip or knee replacement? So is this labor intensive, cost a lot, or what's your experience? Karina, maybe?
Well, we have it already here. I cannot talk for all Canada, but we already have the care here. So it wasn't more time for physical therapists or the nurse. I would say it's even less time for them because the patient are more functional. As our patient said earlier before, he was able to walk already after 3 days. So he was ahead of the program. So it's less work, I would say, and it's already implemented here after surgery for a standard hip. So it's the same or even less.
Perfect. Thank you. Jimmy, don't hesitate if you want to jump in with further questions.
Claude,
Pascal, there's one in. Go ahead.
If I want to reinforce what Karina said, when we started the first case of day surgery, there was a lot of anxiety for us. You know, we were not sure that how it will work at home with the nurses, the physio, and everything. We thought it would be challenging for them to take care of our patient, but in fact, after a few weeks and months, we saw that the workload outside the hospital was much less. The nurse said, I don't need to see your patient, they're doing too well. The physio said, oh, the patient, the first day is like my patient at 4 weeks. So this was a surprise for us. So don't think that you're putting more workload outside the hospital, you're putting less.
Perfect.
And yeah, I'd agree with that, if I may. I think that we found that in the current climate where we've got nursing shortages and higher acuity of patients on the ward, we actually found that a well-motivated and educated patient with a caregiver and a very simple pain diary are getting their multimodal analgesia in a much more scheduled time than they would if they were in hospital. So they're actually having a better experience at home from a pain perspective.
Thank you. Jimmy, you want to? We interrupted you, so
Pascal,
sorry about that.
Pascal, there's a question in there saying, asking whether or not for these patients that you're doing day surgery on, are you doing the procedures and the trainees are not really involved? I can say in London, it makes no difference for my residents and fellows whether I'm doing an outpatient or somebody staying overnight. They do the surgery along with me the exact same. But do you change what you're doing with your trainees to try to get the success of an outpatient?
I think so. Personally, I'm more involved in the surgery for the outpatient. I want to minimize blood loss. I want the surgery to be shorter in time. But this is linked to academic setting. I think that day surgery can be performed in all hospital, non-academic as well. And then the surgeon will be doing the whole surgery himself as. So I don't think it's a major problem.
Yeah, like I said, we the trainees in our place do it exactly the same with us, whether they're an inpatient or outpatient. We don't really change it at all, and the OR time doesn't change that much. So another question I had for you, I know in one of your slides, Pascal, you had sort of this would apply to 60 to 70% of your patients that you could look at potentially doing an outpatient. I want to kind of flip that around for you. What are the red flags? Who are the patients that you should not kind of go down this road? Are there any people that you're a full stop for any reason say, no, that definitely has to stay in the hospital?
I mean, for sure there are medical reasons, like patients that need ICU after surgery, have a high risk of the bladder retention, a chronic hemophilic patient, things like that. But the most important factor that prevent patient selection in my practice in Montreal are patients who live alone. And they say, I'm 70 years old, I have no family, no friends, and I'm by my own at home. This is probably the most important factor preventing inclusion of more patient. But overall, I say it's probably during the pandemic, I was able to continue operating in the last 2 years, doing 2-3 cases per day because I was doing day surgeries. So it saved my elective practice even in the COVID.
Okay, great. Karina, a question in the chat that would probably apply for you. What are the mobility restrictions that you have? I would assume that this question is hip precautions. Are there any precautions on the outpatients, or do you have anything that you tell them not to do for the first 6 sort of weeks after surgery?
From the technique that we use with our surgeons at our hospital, they don't have any restrictions. So that is great. They can move whenever they want. They can do the movements they want. We just ask them not to force any movement, like very hip flexion, very high, like over 90 degrees, and they would grab their knees and up to their stomach. So that we don't want them to do. We don't want them to push movements. If it hurts, they stop. But there are no restrictions with our patients after surgery with the approach we have.
Francis, why don't I ask you a question? Is there anything that you wish you did know going, now you've been through it and you said it was great. Is there anything that you wish you knew ahead of time that the team listening might want to tell their patients or make sure they get?
Actually, you know what? I mean, I see a lot of questions go by, you know, about the preparation and the interaction with the patient. And I must say the experience I had, at least back in 2018, was really good on that. Like in the pre-op a few weeks before, the pre-op session, like Karina mentioned, I mean, you meet the whole team, basically the relevant stakeholders, and you get, you know, the exercises ahead of time. There's a lot of communication, you know what to expect. I mean, I was also involved in the process, maybe more so than I would say perhaps the average patient, because it's my personality and I want to be involved in that. But in my case, it was pretty seamless. I mean, I see questions about the number of sessions that you're allowed here in Quebec. As I was living pretty far from the hospital, I would say the geographical limit of what Pascal mentioned as one of the criteria. So it was done remotely by a regional healthcare center near where I live. So everything was well coordinated. You know, I received about 3 or 4 house visits from PTs. Then as soon as I could drive, I went directly to those facilities to get those services. But all in all, I mean, after 2 or 3 weeks, it was done, you know. I mean, maybe 4 weeks of PT, and then the local PT told me this is the max we can do. I mean, you've attained every objective, and I mean, there's nothing more at this level we can do for you. So no, what I always tell patients or friends of mine who want to undergo such a surgery, and they seem to be more and more numerous as the years go by, is get involved. I mean, you know, ask questions, do some research. Don't just expect, you know, the surgery date and then ask questions then. Be prepared. And if you're prepared, everything goes well, usually.
Okay, great. We're running a little tight on time. Maybe one more question for Pascal and Jacques. Maybe one of the questions in the sequence asked, you know, what percentage of patients you intend to send home but get to the end of the day and they're just not going to go? So what's the failure conversion of an outpatient to staying overnight, and what reasons might that be?
I mean, I could talk quickly, and then Pascal has probably got more experience. But in our experience, we've done well over 100 cases that have gone home. Our success rate is, I just think it's 91% of sending patients home, which really means sending them home before 6 p.m. So if we really looked at what our success rate was of less than 24 hours, then it would be, it's 100% or more. But yeah, so that, if that answers your question.
So is the 6 p.m., lack of physio support or something, or that's just like a line in the sand, that's like a drop dead admission time, or what is, if you had longer resources, presumably they could go home?
Correct. And thanks. Yeah, I forgot to answer that part. It's unfortunately a multiple things. We haven't really been able to pin down one single thing. I think we've had about 2 patients with pain issues. 1 or 2 were really just not good patient selection. Patients changed their mind on the day of the surgery. And then we also had physio and resource issues. So it really is a multitude of things.
Okay. Pascal, anything to add on that topic?
Exactly the same result as Jacques. I mean, a 7% failure to be discharged on the same day, and multiple reasons. I mean, not only one factor is just because our protocol is able to reduce the adverse event rate, bring down, let's say, vomiting from 24% to 1%, but still it's not 0 for all adverse events. So there are still some occurring once in a while.
Okay. Claude, I'll turn it over to you. I think we're getting tight on time here.
Yeah, thank you so much, everyone. It's we were over 350 participants. We received over 60 questions, so obviously we could not answer all of them, but expect to receive an email within the coming few days from the COA with all the references that were presented tonight. And please go and visit the link, the pre-care link. This is where we have the digital patient education tools for pre-op, and also the exercise for post-op recuperation at home. And people were asking for doses and that type of things. So it will all be in the pathway that you will receive via the COA email. And I believe that the COA, it is going to be an output from this webinar. Either it's going to be slides or maybe it was recorded. So that will be available. And in the email, they will tell you exactly how to get a hold of these resources. So thank you so much. And don't forget, and I forgot to mention that the digital resources that we have are in French and in English, and the English version is translated in more than 20 different foreign languages that are spoken currently, commonly spoken in Canada. So very, very easy for your patient to be really well informed in their own language. So thank you so much for your participation. Thanks to the panelists, and thanks to the speaker. Thank you, merci beaucoup, Monsieur Larin, for your experience. And Dr. Howard, thanks for co-moderating this. And I would like also to extend my thank you to formerly CPSI, which is part of the Healthcare Excellence Canada, and the COA and Bone and Joint. We're all working together to improve outcome for hip and knee replacement. Thank you very much.